lecturers, Professor Schaaf and Dr. Anthony Garcia-Prats. Professor Schaaf is a professor and senior specialist at the Department of Pediatrics and Child Health, Faculty of Medicine and Health Sciences at Stellenbosch University and Tygerberg Children's Hospital in Cape Town, South Africa. He completed his pre-graduate medical studies at Stellenbosch University and received his doctoral degree in drug-resistant tuberculosis in children at the same university. He is an active clinician, and his research is on childhood TB with special focus on MDR-TB and TB drug pharmacokinetics in children. Dr. Garcia-Prats spent 6 years with the Baylor International Pediatric AIDS Initiative doing pediatric HIV care and program development in Lesotho and Tanzania upon completion of his residency training in pediatrics at Baylor College of Medicine in Houston, Texas. He is currently based at the Desmond Tutu TB Centre at Stellenbosch University in Tygerberg, South Africa, where he is doing clinical care and research in children with drug-resistant tuberculosis, with a focus on the pharmacokinetics and toxicity of anti-tuberculosis drugs in children. His areas of interest are HIV, tuberculosis, and drug-resistant tuberculosis in children, and pediatric care delivery in resource-limited settings. I will now turn you over to Dr. Garcia-Prats. Thank you.
Thank you, Evgenia, for that introduction. And on behalf, this is Tony Garcia-Prats, and on behalf of Professor Schaaf, we'd like to welcome you to this session and thank you for joining us. We're very happy to be here, and we hope you find this to be a practical and informative session. Please do feel free to submit your questions as the session goes along, and we'll do our very best to answer them as we're able. Our objectives for this session is that by the end, you should be able to list the adverse effects that are associated with the drugs used most commonly for MDR-TB treatment in children. We'd like you to be able to describe an approach for routine monitoring for adverse effects, and also to describe the management of the most frequent clinically relevant adverse effects. So essentially, we want you to know what adverse effects to look for, how to look for them, and then what to do if you find them. Before moving to the specific adverse effects of different drugs, we'd like to discuss some background and sort of general principles of adverse effects and treatment of MDR in children. Adverse effects can be more difficult to assess in children than in adults. It really takes an astute clinical examination and close history, and it's important to really pay attention to what caregivers report to you about how their children are doing. So that's the bad news, that it can be more difficult to assess for these AEs. The good news is that overall AEs are less frequent than in adults. So that doesn't mean that you don't have to worry about them or look for them, but they are less frequent and generally less severe. It is important to do a baseline assessment for some AEs. It's possible that some problems may exist before the start of treatment, and that can be important to know at the beginning, and that's particularly true for hearing assessments, and we'll discuss that in more detail a little bit later in the session. But baseline assessments are important to do where possible. Rather than identifying and treating AEs, it's best practice to actually limit AEs. And one of the best ways you can do that is actually by prescribing and dispensing the correct doses of each drug. And we know that children's, as they go along, their weight changes and increases generally, and so the doses of their medications change over time. There's challenges with not having child-friendly drug formulations. So it's really important to pay attention and be sure that you're giving the correct dose of each drug to the child, and something you should assess at each visit you see a child with MDR-TB. Not all adverse effects are serious, and few actually require stopping or changing of the drug. So that is good news. That doesn't mean you don't need to look for them or to manage them, but rarely are they so serious that you have to interrupt treatment or change drugs. But some of the adverse effects are actually quite common and can occur with many of the drugs. So skin rashes, nausea and vomiting, these non-specific AEs are caused by a number of the different treatments, and that can be difficult to can make it difficult to attribute to one drug or the other, but also makes these non-specific effects to be more common. We mentioned that the best way to limit adverse effects is actually to make sure that you're appropriately dosing all of these drugs. And that can be particularly challenging given the formulations and the fact that children's weight changes over time and that each child has to have a different dose based on their weight. There are tools that can help you to do that more easily. And on the screen you'll see the MDR-TB weight-based dosing chart for children. This was developed by the Sentinel Project, and it's freely available online at the URL at the bottom of the screen. This has weight-banded dosing for all of the second-line and TB drugs and the first-line TB drugs that are used for MDR-TB treatment. And I would encourage you to get this online and to use it in your practice. Just as a reminder, before we move on to the specific adverse effects, to look at the WHO drug groups in MDR-TB treatment. Group 1 are the first-line drugs. This includes INH and RIF, although those aren't routinely used for MDR-TB treatment. And then ethambutol and pyrazinamide, which are frequently used in MDR-TB treatment in children. Group 2 are the second-line injectable drugs, kanamycin, amikacin, or capreomycin. Group 3, the fluoroquinolones, ofloxacin, levofloxacin, or moxifloxacin. And there's a substantial body of evidence and experience that levofloxacin and moxifloxacin are probably better drugs than ofloxacin against TB, though ofloxacin is still used in some settings. The fluoroquinolones really are the best currently available second-line drug being used for MDR-TB treatment. Group 4 are the oral second-line drugs. This includes ethionamide or prothionamide, cycloserine, taururzidone, and PAS. And of note, it's important to be aware of the implications of INH, the INHA promoter region mutation, which does actually confer resistance to ethionamide. So if you have that information available from your drug susceptibility testing, that can be important for your treatment decisions. The group 5 drugs are drugs with uncertain efficacy, and there are a lot of these drugs. We're only going to discuss 3 of them today. High-dose INH is actually considered a group 5 drug, and it's particularly useful if there's low-level INH resistance, which is usually associated with an INHA promoter region mutation. The CATG gene mutation is the other common cause of INH resistance, and that usually causes high-level resistance. And linezolid and clofazimine are other group 5 drugs that are increasingly being used mostly in extensive XDR disease. If you're taking care of children with MDR-TB, this picture may look familiar to you. This is a single day's dose of medications for a child with MDR-TB and HIV. Just to remind you about the really high pill burden and all the different drugs that children are having to take on a daily basis. Number one, this is difficult for children to tolerate. And number two, it's actually difficult to attribute different adverse effects to specific drugs, and this is clinically a challenge and also a challenge for research. As you can see, the citation on the page, this is a review of pediatric use of second-line anti-TB agents. It's a really extensive review of all these drugs in children, what is known, and I would encourage you to take a look at that. So moving on to the specific drugs and adverse effects that you can expect and look for. Looking first at group 1, the first-line drugs. Ethambutol and pyrazinamide are often still used in MDR-TB treatment. Because they're first-line drugs, most of you are probably quite familiar with the adverse effects. Ethambutol can cause optic neuritis, and this can result in decreased visual acuity, but often it first presents with changes in color vision. So that is something that can be screened for in older children and adults. And if you identify that early and stop the ethambutol, the optic neuritis is actually reversible. Ethambutol is renally eliminated, so you should use it with caution in patients with renal impairment. It is important to note that even though you cannot assess visual acuity very well in young children, that's not a contraindication to using ethambutol if it's otherwise indicated. And at the recommended doses, it has been shown to be quite safe. Pyrazinamide is well known to cause hepatotoxicity. It can also cause arthralgia, and in children this is actually quite rare. There is some suggestion in the literature that it may be more common if used along with fluoroquinolones, mostly in the setting of preventive therapy, but we have not seen this very frequently. Pyrazinamide can also cause skin rashes and photosensitivity. So now moving on to the group 2, the second-line injectable drugs. And these are probably the most toxic and most poorly tolerated of all the MDR-TB drugs. All of them have similar adverse effects, kanamycin, amikacin, and capreomycin, essentially. They are known to cause nephrotoxicity and electrolyte disturbances, hypokalemia being most common, but hypomagnesemia also being possible, particularly with capreomycin. But in our experience and in the literature, these are actually uncommon in children. They're much more common in adults, and we've very rarely seen these, although you can't ignore them and you should look for them. Ototoxicity, on the other hand, is actually quite common. Depending on the cohort that you look at, up to 50% of adults treated with long-term injectables will end up having some degree of hearing loss, and maybe as high as 20 to 25% in children as well. The hearing loss is permanent sensory neural hearing loss. These drugs actually kill the hair cells. It results in high-frequency hearing loss first, most commonly, and as the damage progresses, it progresses into speech frequencies and into lower frequencies as well. There can be acute severe hearing loss that is possible, although it's not common. There are genetic markers that predispose to having ototoxicity from these drugs, but these are also uncommon, and most people who end up with hearing loss will not have one of these markers. It is important clinically to note that the hearing loss may continue after you stop the drugs, and the literature suggests that this may happen for as long as up to 6 months after stopping the treatment. So that's relevant when you're screening and looking for hearing loss. You can't assume that there won't be any damage once you've stopped, and you should continue looking for up to 6 months after stopping. Vestibular adverse effects are possible, but has not been well studied in children, and in our experience is not very common. So how should you look for hearing loss? How should you monitor for ototoxicity? The main ways are for using pure tone audiometry. And this would be in older children. Generally, children greater than 5 years of age, and obviously adolescents and adults, are able to cooperate with pure tone audiometry assessments. For younger children, you can use otoacoustic emissions, or OAE. And this doesn't require their cooperation with the tests, and it can tell you about their hearing thresholds. It is important to ensure that the machine that you're using to check OAE can actually test high frequencies. Not all machines can actually do that, but it would be important in this context. But it's also important to assess the middle ear via tympanometry or otoscopy to look for conductive hearing loss. In middle ear infections, perforated otitis media, these are actually quite frequent in this population, particularly in those who are HIV infected. And that can also cause hearing loss, but that's distinct from the sensory neural hearing loss that is caused by the injectable agents. So in order to interpret the results of your pure tone audiometry or OAE, you really have to also assess the middle ear. And this, because it's so common and so clinically important and can be severe, you really should routinely screen for hearing abnormality if you're able. It's important that you cannot rely on subjective report of hearing loss or gross evidence of hearing loss. Because the damage begins at high frequencies, which is above the speech threshold, damage can be going on before your patients are reporting any hearing loss. And obviously, youngest children may not report, can't report hearing loss to you. And if you're already seeing gross evidence of hearing loss, you're intervening too late. We recommend doing baseline hearing screening and then monthly thereafter. Here the baseline is actually quite important because if they have pre-existing hearing loss or hearing deficit, if you don't know that before they start treatment or shortly after they've started treatment, you may interpret later abnormal hearing tests as related to your injectable when they're actually not, and they were pre-existing problems. If you have an abnormality during routine screening, then we recommend screening more frequently. And I would also refer you to this nice citation, Hearing Loss in Children Treated for MDR-TB by James Seddon and Prof. Schaaf. In this retrospective study of children treated for MDR-TB with long-term injectables, 24% had definite hearing loss, and this was using quite strict criteria. So this is not a rare side effect, and you need to be aware of it. So case number one, we'd like to share this case with you quickly. You're taking care of a 3-year-old girl who has confirmed MDR-TB and extensive pulmonary infiltrates. She is on treatment with high-dose INH, pyrazinamide, ethionamide, taururzidone, levofloxacin, ethambutol, and amikacin. And she's now on month 3 of treatment. Her second culture after 1 month of treatment was positive. During routine monitoring, her OAE shows high-frequency hearing loss at 6,000 to 8,000 hertz bilaterally. Her baseline OAEs were normal. During your assessment, you did not identify any other AEs of importance. So our question to you, how are you going to manage this case? One, are you going to tell the mother the child is better off deaf than dead? 2, see if there is an alternative drug available to exchange with amikacin. Stop amikacin injections irrespective of culture results or improvement of child's TB. 4, continue amikacin irrespective of culture results or improvement of child's TB, or 5, none of the above. Okay, yeah, thank you for giving those answers. I think most of you are on the right track. This is not an uncommon scenario. This is not an uncommon scenario at all. Of course, better deaf than dead is not an ideal option either way. And of course, we don't encourage you to tell the caregivers that. What you need to do is a number of different things, and really these cases need to be managed on an individual basis whenever possible. Number one, you need to consider the clinical progress of the child. So how are they doing? Are they gaining weight? Have their symptoms resolved or significantly improved? Are they looking clinically well? How is their chest x-ray? Has it markedly improved from baseline? Are they appear to be clinically responding to their treatment? Your month 1 culture was positive, but do you have any culture results since then? Is their culture now negative at month 2? You're really looking for evidence of clinical improvement, or whether this child still has a long way to go and is quite ill. Number 2, you need to consider what other treatment options you have that are available to you. Possibilities would be PASS or potentially linezolid, depending on your setting. Can you get access to those, and could you give those to this child? And number 3, do you have drug susceptibility test results for second lines? It would be important to know whether the isolate that is causing this child's TB is resistant to fluoroquinolones or susceptible. If they're resistant to fluoroquinolones, you'd be much more hesitant to stop the injectable drug, which would be a really important drug in the child's regimen. If the fluoroquinolone is susceptible, then that may make you more confident in potentially stopping the injectable. And of course, if you have evidence that there's already a second-line injectable resistance, then you could clearly stop the injectable and probably shouldn't have started it from the beginning if you knew about that. When we see these initial screening results that show abnormal hearing results that look like could be sensory neural hearing loss related to injectables, we will evaluate again in 2 weeks. And if the results are the same or there looks like progressive hearing loss, then we will consider stopping the injectable drug if the child has had good improvement, if there's another drug available and there's no fluoroquinolone resistance. But it is important to individualize each case. In many children, you can actually safely stop the injectable, and they'll have good outcomes. But there are other children who have extensive disease, who have extensive resistance, and whom it may not be in their best interest to stop the injectable.
Well, good afternoon. It's my turn. It's Simon speaking. And I see there's a couple of questions, and maybe I should start with some of the questions. The first question there is about screening of the vision with ethambutol. And what we have done, we have downloaded from Google actually Ishihara chart. It's a chart with numbers. And even though the children can't read, many of the children at the age of 5 can actually follow the lines with their fingers rather than reading the numbers. So that is an option. It's not that child-friendly, but certainly an option that one can use and that we have used with success in most children 5 years and older. In the second question, there is about capreomycin, the use of capreomycin in children. Certainly an option. The reason why we do not use capreomycin, well, it was at first not available in South Africa, but also capreomycin has a higher MIC compared to amikacin. So we prefer to use amikacin in children. It is often said that capreomycin causes less hearing loss compared to amikacin or kanamycin. I have looked for evidence of that in the literature, but could not really identify that evidence clearly. And I think we need to have a comparative study to really truly know whether that is true or not. I was just read the other question in terms of efficacy. Would you be comfortable substituting PAS for amikacin? If there are signs of early ototoxicity? Yes, certainly. PAS is actually quite a good drug. To be honest, there's questions about the efficacy of amikacin and kanamycin. If one looks at EBA studies, early bactericidal activity studies, amikacin and kanamycin actually has very little activity. Now that could be that the activity is over a longer term or longer period, but PAS certainly does have good activity against tuberculosis, and I would feel quite comfortable to replace PAS or replace injectable with PAS. A question about clarithromycin and the use of clarithromycin. Unfortunately, clarithromycin is not that good Mycobacterium tuberculosis drug. It's a good drug for non-tuberculosis. Mycobacterium is actually the best. But for tuberculosis, there's very little evidence that it really works well. Some studies that I read only said that sensitivity to clarithromycin is around 12% only. So it's not a good alternative for any of the other second-line drugs currently. So now we can start with group 3. Actually, I must give back to Tony because he said he was going to do the fluoroquinolones, but that's fine. You want to continue?
Sure. Sorry. So let me do the group 3 fluoroquinolones before handing off back to Prof. Schaaf. There was initially a lot of concern about using fluoroquinolones initially in children based on animal data that showed juvenile animals had arthropathy or tendinopathy with fluoroquinolones, but that hasn't played out in humans. And there's actually far fewer adverse effects with the fluoroquinolones in children than was anticipated. In fact, arthralgia and arthritis is actually very rare in the literature and also in our experience with using in relatively high doses of the fluoroquinolones that are recommended in MDR-TB treatment for prolonged periods of time. Actually, the adults seem to have more problems with arthralgia and arthritis, including tendon rupture. We just haven't seen it very frequently ourselves. Neurologic adverse effects have been well described, and we do not infrequently see insomnia, sleeplessness, or nightmares in children starting fluoroquinolones. It's usually early on in treatment, shortly after starting. It's rarely serious enough to interrupt the treatment or decrease the dose, but it can be concerning to parents, and it usually, in our experience, resolves after a short amount of time. Now, hallucinations and more serious central nervous system effects can be seen, but generally in overdose, and that's the context that we've mostly seen it in accidental overdose. Headache, dizziness, drowsiness, and other non-specific adverse effects like abdominal pain, nausea, and vomiting are possible, but rarely that severe, and can be difficult actually to attribute to the fluoroquinolones in the setting of multi-drug treatment. The QT prolongation is a known class-wide effect of the fluoroquinolones. It is mostly associated with moxifloxacin, and levofloxacin and ofloxacin really do not look to have a very substantial effect on the QT interval. There's very little documentation in children. We've done some initial studies and have seen no QT prolongation, but this is in a small number of children, and I think there's some additional data that will be needed. But this is not really a clinically significant adverse effect that we know of at this point in children. And it's not necessary to screen children with ECGs or also to monitor them with ECGs. I'm going to hand it back over to Prof.
So now we're continuing with the group 4 drugs, which is the oral second-line drugs. And you have heard the drug names. It's ethionamide, prothionamide, and then also pyrazidone or cycloserine, and para-aminosalicylic acid or PAS. We start off with ethionamide. That is what we have, but in other countries there may be no ethionamide but only prothionamide. They are very similar drugs and they have exactly the same adverse effects. So the most common that we see with ethionamide is gastrointestinal disturbances, mainly nausea, vomiting, some abdominal cramps or pains, and also has a terrible taste. It has a metallic taste and it's all really hated. The vomiting often occurs in the first week or two on treatment. We usually have two ways of managing that. First, one can lower the initial dose and work up the dose to the end of the first week to the required dose. Or more often we just split the dose. That means instead of giving the full dose together with the other anti-TB drugs, we will give half in the morning, half in the evening, and if they do vomit a lot, we will give it separate from the other drugs so that at least we know the other drugs are going in. Hepatotoxicity is also a problem that we can also... Sorry, the phone is off the hook. I don't know why it rings. The hepatotoxicity can also be a problem, as in the first-line drugs. Hepatotoxicity with ethionamide is very uncommon, but it certainly can happen. It usually presents with new onset vomiting, with abdominal pain, and also sometimes with jaundice, but that is really if one misses the first signs. Very rare with ethionamide is convulsions, peripheral neuropathy, because ethionamide is associated or very a drug close to isoniazid, so it's in the same group of drugs, and it's also these neurological side effects are pyridoxine responsive, and we do start all our patients on second-line therapy on pyridoxine supplementation. A very rare side effect that we have seen is gynecomastia. Gynecomastia in boys that develop, and by stopping the drug it is reversible. And then we also note that diabetes may be more difficult to control with ethionamide, and we have not had many diabetes patients, but diabetes in general with an ill child is difficult to manage. So we don't know what the true effect of ethionamide is and what the effect of just the disease itself is on the management of diabetes. So there's an article that you can read by Steffi Thier in International Journal of Tuberculosis and Lung Disease 2011, where we described our experience, a retrospective study on the thyroid functions tests in children. It's important to understand that thyroid function abnormalities can be present already before you start the treatment with ethionamide, and the other drug is paraminosalicylic acid that can also cause thyroid dysfunction. Therefore, it's important that we do have or do get a baseline thyroid function before we start the treatment. And after we have started the treatment, we usually do 2 monthly TSH and free T4 levels in the children to see whether we have an increase in the TSH and a decrease in the T4. With just an increase in TSH, we will not supplement, but usually if the free T4 decreases, then we will supplement, because the thyroid hormone is important for children's normal brain development. So for that reason, we do supplement them. And we start with a very low dose of 0.05 milligram for the younger, for any children. And if that is not enough in the older children, we'll go up to 0.1 milligram as a total dose. Hypothyroidism is reversible, so once you stop the ethionamide or PAS, then the values usually return, or almost always that we know of, return to normal, so you can stop the supplements of levothyroxine. So the second drug that we commonly use is trazodone, and in other countries it will be mainly cycloserine. The side effects or the adverse effects of that drug or drugs, these drugs are similar, is mainly neurological system adverse effects. It is dose related, so the higher the dose, the more commonly it is. And it presents with anxiety, confusion, depression. It could present with psychosis, and in some cases convulsions. It is much more common in adults than it is in children. We have not seen in our children any of these side effects due to trazodone. We have seen it with a high dose, or even with, in some patients with normal dose INH, but we have many more patients on INH than that we have on trazodone. Depression we do see in children, but the depression is usually due to the severity of illness rather than the trazodone, and they come in with a depression rather than when we start them on treatment. And in such cases, we do use an antidepressant in these children, and we watch them closely. We do give pyridoxine supplementation in all our patients on trazodone or cycloserine, and the dose that I use is 25 milligrams, or 1 tablet for every tablet of trazodone or cycloserine that we use. And if this happens, one can try to reduce the dose, and if that doesn't work, one actually has to stop the trazodone or cycloserine, and as I say, that is much more common in adults than it is in children. Paraminosalicylic acid, or PAS, is quite a terrible drug for adults to take. They do not like it at all. The children cope with it quite well, although there are some children that really complain. And again, the main disturbances that we get is gastrointestinal of origin, so anorexia, so they don't feel like eating. They often have diarrhea initially, but that often clears after a while, and then of course nausea. I don't think there's a real answer to management of this. One needs a good dose of PAS, and we use 150 to 200 milligrams per kilogram per day as either a single or divided dose, and it does not seem to make a difference whether one gives it as a single dose or a twice a day dose in the GIT disturbances. Hypothyroidism, as I mentioned with ethionamide, is the same for PAS, and if it's used in combination, so both ethionamide and PAS, it is more common. And it is also more common in HIV-infected patients. And these patients then do need supplementation if the free T4 is low. And again, ethionamide can cause hepatotoxicity, but also PAS is less likely to cause hepatotoxicity, but it is also a hepatotoxic drug. So we come to our second case, a 4-year-old boy on pre-XDR tuberculosis treatment. Now, pre-XDR, I'm sure that most of you will understand that. Pre-XDR means MDR plus resistance either to amikacin or the injectables, or then the fluoroquinolones. But he presents with new onset vomiting after 2 months of treatment. The current treatment that the patient is on is high-dose INH, PZA, ethambutol, ethionamide, trazodone, levofloxacin, and capromycin plus PAS. He's also on pyridoxine, a supplementation to counteract the adverse effects. He's HIV negative, and although he vomited initially a few times when he started his treatment, this had stopped after 1 week of treatment. And on examination, he has no skin rash, no neck stiffness, no diarrhea, but looks slightly jaundiced with a palpable liver edge. So, what is the diagnosis and how would you manage this child? And we'll put up the slide for you to answer. Okay, it seems like as you read through the possible answers and you come to the last one, people realize that all of the above could be correct. And that is actually the correct answer in this specific patient. So, clearly this child should be considered as having hepatotoxicity or some other kind of hepatitis. But in this case, one has to stop all the hepatotoxic drugs. And the reason for that is that hepatotoxicity, if you do not, in the severe case, like in this case the child already had jaundice, if you don't stop it, the patient can actually die from acute liver failure. The signs of hepatotoxicity, as I already mentioned, the first one that we often see is new onset vomiting. Now, it's not the only cause for new onset vomiting, and therefore one needs to exclude other causes. I've mentioned that we did exclude it clinically in some of them, but others need to be excluded. And then the second sign that we see is abdominal pain, usually over the liver or the liver area. And then a late sign is jaundice, developing jaundice in the children. So as I say, we have to stop all the liver toxic drugs, and we can continue with the liver friendly drugs as long as you have a combination of drugs to use. We do the liver function tests, and especially the ALT is important And we wait until the ALT is back to normal before we will reintroduce those drugs that we think is essential for the further management of this child. And very rarely we will find that the children develop problems or hepatotoxicity again on any of the drugs that we do reintroduce. One has to screen for hepatitis A, even hepatitis C. In our situation, hepatitis B is very uncommon because the children are immunized. But those are, I think the last question, the last answer was then the correct one. One has to screen for other causes. One has to screen for the possibility if there's a conjugated hyperbilirubinemia, that could be due to obstruction from the lymph nodes in the area of the biliary tract. So then we get to the group 5 drugs. We often use, or we use in almost all our patients, high-dose INH in combination with ethionamide, because one of either ethionamide or high-dose INH is likely to be effective. And the reason for that is, as Tony has explained, in an INHA mutation, we have cross-resistance with low-level resistance to INH, but resistance to ethionamide. And with the CAT-G gene mutation, we have high-dose or high-level resistance to INH usually, with susceptibility or maybe susceptibility to ethionamide, because there are other mutations that can also cause ethionamide resistance. But the combination of the two usually gives us a good possibility of one of them at least working. The question is there danger or a higher danger for hepatotoxicity? Because we do not use it in combination with rifampicin, actually the risk is very low, even if you use it at a high dose. And peripheral neuropathy, that we provide pyridoxine supplementation for, and we have not seen that with our patients. The second group 5 drug is clofazimine. Now, clofazimine has only been recently been used, being used for tuberculosis, and unfortunately, the dose is quite difficult in the case of children. The adults have reduced their dose from 300 to 100 milligrams per day, and previous dosages described in children was between 3 and 5 milligrams a kilogram. But even that dose in the younger children is difficult to achieve because of the size of the capsule, and you cannot actually divide the capsule because it's a fluid inside of a gel capsule. So in some cases we will give every second day because it also has a very long half-life. But we are concentrating on the adverse effects in these patients with these drugs, and we use it mainly in children who have pre-XDR or XDR tuberculosis. It can cause red color of the urine and the feces and the sweat, but the main problem that we are aware of, and which the adults really do hate, is the red, brown or very dark pigmentation of the skin, which does resolve, but it can take months to years to change back to basically normal. So that is not something that one would like to have, but in the few children that we have used it, we did not see a great change, but all of these patients were dark-skinned patients. Gastrointestinal tract problems, diarrhea, nausea, vomiting, not very common. Skin rashes can occur, and then there's also the question of Q2 prolongation, which I'm not aware of any studies in children up to this stage. Then the one drug that is being used much more commonly these days, and will probably be used much more if it becomes less expensive, is linezolid. Linezolid, an antibiotic, very effective against tuberculosis in our experience, and we have used it for about 10 patients with MDR-TB, and all of those patients have survived. So we are very positive about the use of linezolid. But the side effects described in adults are quite extensive. It can cause severe myelosuppression or bone marrow suppression, such as anemia, leukocytosis, and thrombocytopenia. I apologize for the spelling mistake. It can cause peripheral neuropathy and also optic neuritis, pancreatitis, lactic acidosis. But all of the above we have very rarely seen in our patients, and I think that has to do with the dose, because it is definitely dose related. So we do give 10 milligrams a kilogram twice daily for the children under the age of 10 years, and for the older children we give 300 milligrams a day as a single dose. And we only manage children up to the age of 14 years of age. And with that dose, we have only seen in our HIV-infected patients any side effects, and all the HIV-negative patients, we have not seen a single adverse effect. So it is a drug that I think is one can use, but we need to be very much aware of the side effects, and it's important, especially to look for the neuropathy, because the neuropathy takes very long to cure, or if it, in adults I even describe that it is irreversible, but in the children that has been described, it has reversed. The one reason that we had to stop linezolid in one of our patients was lactic acidosis, because that can be fatal. And with myelosuppression, one can initially lower the dose and see whether it responds, but it sometimes does need blood transfusions. We have not had such a case with the dose that we're currently using, but in adults it has been described. I think one needs to be aware of it and do regular full blood counts. So the third case, and I see we're running out of time with quite a number of questions. But the third case, a 4-year-old girl with MDR-TB and recently diagnosed HIV infection. She was first started on MDR-TB treatment with PZA, ethionamide, ethambutol, trazodone, levofloxacin, and amikacin, and 2 weeks later on ARVs, abacavir, 3-TC, and efavirenz. And she was also on cotrimoxazole, pyridoxine, and vitamin B co. 1 month later, she presents with severe maculopapular skin rash, fever, and general malaise. Now, maybe it's not a good thing, but I did not put in the answers for you to answer, but we will continue. The question is, what is the cause of skin infections? There are skin rashes. There are many, many causes, and it could just be that this child having HIV has an intercurrent infection, most likely viral, possibly bacterial. But on the other hand, it could also be a drug adverse effect, and then it could be both from either the anti-TB drugs or from the antiretroviral drugs. And in our experience, probably the most common reason is cotrimoxazole. One needs to be aware of abacavir and its hypersensitivity reaction, which can be very serious, and in that case abacavir should be stopped and never be used again, but that usually presents earlier than 1 month after starting the treatment. If the skin rash is not severe, one can most likely continue with the drugs and watch the skin rash and watch the development of the patient, the adverse effects. In HIV infection, we also need to be very much aware of the problem of Stevens-Johnson syndrome, which can develop with quite a number of drugs. And if that is the case, then all drugs should be stopped. And in the severe skin reaction, all drugs should also be stopped. When we reintroduce the drugs, in this case, you can still reintroduce the anti-TB drugs one by one, but remember that the ARVs cannot be introduced as single drugs. They should be introduced as a combination of drugs, and one will have to ask the question, which of the ARVs is most likely to cause such a reaction, and exchange that with another ARV if the patient is stable and the viral load and is less than detectable. Otherwise, you can't just change a single drug. So there you need some advice from an HIV expert. And we often have to exclude the cotrimoxazole because we find that that is the most common reason for a severe drug reaction or skin reaction in the children. So what are the possible routine monitoring tests that one should be doing in children on MDR-TB therapy, on second-line drugs. Some institutions will ask for regular testing of ALT, the liver enzymes. We do not do that as a routine. We will watch clinically for vomiting, and we will watch for abdominal discomfort in the patient, and then certainly also for jaundice, and if any suspicion, we will do the ALT and bilirubin, but not as a routine test. With the injectable drugs, it's very important to do the baseline hearing test, as you have heard from Tony, and thereafter a monthly screening, and if there's any indication of hearing loss, even more regularly, 2 weekly, if you have to continue with the amikacin or the kanamycin. And then we also repeated 6 months after completion of the injectable, because as Tony mentioned, the damage can continue even after stopping the injectable. Creatinine and potassium levels, we do 2 monthly. Luckily, in our experience, it's very rarely that we find any problems with the nephrotoxicity in children. Ethionamide and patch, we do regular thyroid functions. We do baseline and then every 2 months. If the patient is only going to be on a shorter course, in our instance, in our institution, we actually use ethionamide, for instance, for tuberculosis meningitis management for 6 months and even up to 9 months. It's probably not necessary to do thyroid functions because it's a short-term management and it's reversible. But if you have to put the children on long-term ethionamide, then certainly 2 monthly follow-up is important. And then lastly, with linezolid, full blood counts at least monthly initially, and later if you see the patient is stable and tolerates the linezolid well, one can defer to 2 monthly tests. Then lastly, we have to come to adherence, because with all these adverse effects and with the difficulty of taking drugs over a very long period of time, adherence becomes even more important, and ways to ensure that the children actually do take a treatment. I don't think anyone has the final answer on what exactly to do to have all patients adhere to their treatment, because even the adults, when they understand and know the disease, are often reluctant to take their drugs. Children are not stupid, they are actually very ingenious when it comes to not taking their drugs, and therefore it's important that one needs to observe the child swallowing the drugs. Someone actually has to see that the child swallows the drugs. It does not help just to give the child the tablets and say, there, drink your tablets and turn around and walk away, because they will find a way to get rid of those that they don't like. Poor palatability of the meds may contribute to adherence problems in some drugs, like especially ethionamide and even PAS. It's important that we ask the children to identify the drugs, so that we can see whether they actually know their drugs. I think that's one way of looking at adherence. It's not an absolute method, but if they know all their drugs and can tell you exactly how many of each they take, and we have a picture of which I will show you just now, that is one way of trying to establish whether they're actually taking the drugs or not. When the children come to me and I have any doubt whatsoever that they're taking their drugs, I do phone the clinics and find out from the sisters who dispense the drugs whether the mother or the child did come for their treatment or not. And children, especially the teenagers, will lie in your face with not a blink of the eye that they're taking their drugs, and the sisters at the clinic say they were never there. So it is important to check. Full counts may help, same as in the case of ARVs. Most important is to identify a reliable caregiver to provide the drugs and to observe the child taking it. The next slide is a photograph that we actually used for the patients to identify the tablets that we have. These are the tablets that we currently use in the Western Cape, in South Africa, and the moms or the children will actually say, I take one of those, 2 of that, and that helps us a lot to establish firstly the correct dose, that they're taking the correct number of tablets, and secondly, whether they know their drugs or not. So adherence, finally then, it's important also to monitor the adverse effects, because that could be a reason for defaulting treatment, and we should try and help the patients if we can. It's not always possible. We are very reluctant to give antiemetics to children because that causes its own problems in the case of children, but in teenagers that is a possibility. Teenagers are a notoriously difficult group to adhere to treatment, and the way that we communicate to teenagers is extremely important. Also the staff at the clinic, we must never scold, never be derogative. We must always try and support rather with positive pressure or positive stimulation rather than be negative against them, because they will stop their treatment just because they don't like you or they think you don't like them. And the other problem that they often have is stigma or mocking by their peers, and they will not go to the clinic just because they are mocked by their peers that they have to go to the clinic. So that is something that we also must try to address in our communities. It's often important also not to give only nutritional support, but also financial support so that patients actually can go to the clinic and that they can access care to get to the clinic and to get their drugs. Especially also if the parents are ill, because they are without jobs in that time. So in conclusion, before we get to the rest of the questions, it's important to know the adverse effects of the drugs used for multi-drug resistant TB treatment. We have to understand these. We have to monitor routinely for each of these important side effects, even though it's more difficult in children than in adults, but it is important that it's done. I think the hearing loss is the most frequent severe adverse effect that we see in our experience on treatment for MDR, and this should be actively assessed, and we should decide whether we must continue or not with the injectable. And adherence support, and I want to emphasize the word support is crucial if we really want to successfully treat these children. So we'll get to the questions. I think that is the last slide. So the first question there is, in a child with MDR-TB with resistance to amikacin, kanamycin and capromycin, where an effective regimen demands the inclusion of an injectable, what is the best option? Well, clearly if there is resistance to all three of the injectables, there is no injectable that will work, and one should actually not give an injectable in that case. Strangely enough, the one injectable that may in that circumstance still be effective is streptomycin. But then you need to have a susceptibility test for streptomycin, and you must have streptomycin available. Often MDR patients are resistant to streptomycin. More than 50% will be already resistant to streptomycin. That's why we don't use it as a second line injectable. But in some XDR cases, we have seen that where there's resistance to all the second line injectables, there is still susceptibility to streptomycin, and that may be a possibility. But it then should be tested and not just given because it has the risk of this adverse effects that you don't want to give if it does not play a role in the management. Is there any drug interaction between levothyroxine and other second-line anti-TB drugs? Not that I'm aware of. And levothyroxine or thyroid hormone is a normal part of the body, and I'm not aware that there is any reason not to give it. The adults I know also give it, although their brains should be fully developed. They still choose to supplement if they see hypothyroidism, so I don't think there's any reason not to give it. Which antidepressant would you recommend? Well, we use fluoxetine with great success in our patients. And once the patients are out of their depression, we will start to taper it after a while, and most of the children actually do very well. Do you have a neurological assessment tool to compare baseline to later neurological signs and symptoms? Not a specific tests, I can ask Tony if he wants to chip in here. But what we do have to our advantage is that we do have physiotherapists and occupational therapists that on our team, which helps us with the neurological assessment of the children, which is certainly of value. And they will quickly come and tell you if there is something wrong. But the peripheral neuropathy is not the easiest to test in the young child. Is there no evidence of conduction defect with linezolid at all? I'm not aware of that. I don't think there is a problem. I'm not aware of that side effect with or adverse effect with linezolid. Is there any role of drug level monitoring for adherence issues? Will it help counseling for adherence? I think there's very little places where drug monitoring can actually be done. The one that can be done is with INH, where one can test it on in the urine, and I suppose it may help. But we have not used it. We don't have any experience with that specifically. So I can't really give you a final answer there. I think it depends very much on what you can actually do. But you can't test too many times because we don't want to take unnecessary blood. But certainly that's something that one will have to consider. But if one has a blood spot test or a dry spot test available, which some people are looking at the current moment, that may be an option. But blood tests for just drug level monitoring to see whether they take their drugs, I think at this stage for us it's definitely not an option. How long time do we use injectables? Well, in children, and there are a couple of articles that we have written on our MDR-TB treatment experience. Children, because they have paucibacillary disease many times, especially if you can identify them as contacts of adult source cases with MDR-TB and you catch them early with only lymphadenopathy and maybe slight infiltrates in the lung fields, one can often get away with 3 or 4 months of injectables rather than 6 to 8 months as used in the adults. But once they develop severe disease, such as in the case of adults with cavities and widespread disease, disseminated disease as miliary TB or TBM, then certainly the injectables at this point in time, with our experience, should be used for 6 months if that is the case. But we also, in a very early disease, will sometimes get away without the injectables, and you can read in, if I remember correctly, it's in Thorax in 2013, article by James Seddon and myself on our experience of children that did not need to go onto injectables, but that is really was very early paucibacillary disease only. And then also one should know that there is no second-line drug resistance in those cases. Just remember that if one excludes the injectable from the treatment, that if you know about the mutation causing INH resistance, if it's an INHA mutation, you already lost quite a number of drugs, including ethionamide, and one should always be aware that you need at least 3 or even 4 active drugs or effective drugs to treat MDR-TB. In the paucibacillary disease, 3 drugs probably fine, but there should be enough drugs to protect the other drugs from developing resistance. Otherwise, you will just lose the other drugs as well. What are the pros and cons using alternate day injectable to minimize total cumulative injectable and resultant ototoxicity? Yeah, that is a very good question. The one article that I know of was written by Chuck Peliquin, where they compared 3 times a week to daily injectables and did not find any difference in the adverse effects. So I don't think the 3 times a week for the reason of preventing hearing loss is the answer. Shorter treatment may be of value because the cumulative dose will be less over a prolonged period of time. But as far as I read the literature, the 3 times versus daily injectables does not make a difference. Should we do a skin test before starting injectable streptomycin? I suppose that is an allergy skin test, but no, not that I am aware of. We will start streptomycin, but as I say, currently streptomycin is almost not available in South Africa. I have used it in 1 or 2 XDR patients where susceptibility of streptomycin was still present while the child had resistance to the other injectable drugs. And the last question, currently, have you seen cases with reactivation of multi-drug resistant TB or XDR TB after completion of treatment and patient becoming symptomatic after a few months or years? The ones that we see that have relapse is not those that are on the second line drugs, but those that were treated with first line drugs. They initially will improve and then they will relapse, and they relapse quite badly. We had one child that I can remember offhand, and we've had many children that had presumptive MDR tuberculosis. We could never culture it, but because the CSF changes deteriorated and the child developed new brain abscesses, we started the child empirically on MDR-TB therapy. We treated him for 18 months, and almost 16 months later he came back with some new tuberculosis in the brain. Now that we never could prove that it was still active tuberculosis or whether this is just an iris, because this child also had HIV. But in general, the children, if managed correctly within the correct number of drugs for the correct period, we find that our patients actually do really well, and relapse is very rare. One should always also consider the possibility of reinfection if they come quite late. Relapse will usually occur within the first 6 months, maybe a year after completion of the treatment. So I think that addresses
I think
the questions.
Yes, I think these were all the questions. Thank you so much. I'd like to thank both our lecturers on behalf of the participants and myself for a very informative and interesting webinar this morning or this afternoon. And of course, thank you for everyone's participation.